Thank you all for joining us today. Good morning, good evening, from wherever you're joining us. We're so glad to have you here. This is being recorded just so we can then have it available to everyone who has registered first via email, and then shortly after that, we will also post it on our YouTube channel. We are so glad you're here today. This is our webinar 2, our 3-part series on cancer predisposition. We want to kick off with thanking all our advocacy partners. All of them have supported us in both advertising and talking about it, and also making sure that we include all of their community information and interests as well. So a huge shout out to all of them. We also want to do a special thank you and a shout out to the patient advocacy team and the medical affairs team at Illumina. They have not only taken a lot of time to create and curate this webinar series at our request. This is the first time that they're doing something on this topic for a patient advocacy organization and its community. So we're very thankful for all the time, effort, and consideration that they've given to us, not only in presenting, but also in putting together this wonderful webinar series. So thank you to all of you. Without any other delays, we just wanted to go over a couple of important reminders for this webinar. Unfortunately, we will not be able to provide, not me, but Emily will not be able to provide any medical advice during this. We want to keep this webinar as broad as possible so it can address the community as a whole with all of these questions and not any specific individual medical cases. We do not have a chat option, so please include all of your Q&A in that section that's specified to it. We will also make sure that if any questions are not gotten to while we present during this webinar, we can email responses to you at a later time. Closed captioning is available, and a recording will be provided at the end of this webinar shortly after. We are complete. Here we go. It is my pleasure to welcome Emily to this webinar as our speaker. She's dedicated so much of her time and energy in not only creating this webinar, but also presenting to us. So thank you, Emily, most of all, for taking time away from your family to share with us all of this information that we all really want to learn more about. Emily Dalton has been a genetic counselor for over 15 years and in the industry for over a decade. She's currently an associate director of oncology medical affairs at Illumina, where she provides education and generates evidence-based information supporting the clinical utility of comprehensive genomic profiling of tumors. Prior to Illumina, she was also at Emory Genetics, starting as one of the first field-based genetic specialists and ultimately growing to support the entire genomic science liaison team as director for 4 years. She started her career practicing clinically at Dana-Farber Cancer Institute. Shout out there. After earning her master's in genetic counseling from Boston University School of Medicine. She still resides in the Boston area, and we are so thankful to her for taking time today to be here. Sit on.
Great. Thank you so much. And thanks everyone for joining. All right, let me get all right. Okay, I had to request to share, Parvati. So if you can give me permission, then I'll pull up my slides. Excellent. Here we go. Wonderful. Okay, so hopefully you can all see that okay. Let me know if anyone is having any trouble. So Parvati, actually,
Emily, okay.
Yeah,
now we can see it. Yes.
You got it? Okay, wonderful. So I was actually just thinking that we, given the kind of spectrum and scope of hereditary cancer syndromes that we're going to discuss tonight, I realized we maybe should have titled this Well-Described Hereditary Cancer Syndromes, because some of what we're going to talk about tonight, as you know, some of the syndromes are actually quite rare. So we're going to talk about a whole spectrum of hereditary cancer syndromes, and we'll talk through the prevalence and different attributes of those. So as Parvati said, I'm Emily Dalton. I am a genetic counselor at heart, and although most of my work now focuses more on tumor testing, my background is really on the hereditary side of things. So really excited to be talking about this topic tonight. And I think we're going to save Q&A for the end, but feel free to drop questions into the box as I go through. So tonight we're going to cover hereditary breast and ovarian cancer syndrome, Lynch syndrome, and CMMRD. Li-Fraumeni Syndrome and neurofibromatosis, as well as just some key takeaways overall when it comes to hereditary cancer syndromes. Before we dive into the specifics of each of those, I did want to provide a brief review and overview of what was covered in the last webinar in case some of you were not able to make it or weren't able to watch the recording. So there was obviously much more content than this, but at a high level, we really talked through what is hereditary cancer and some of the attributes and red flags. And so when we think about hereditary cancer, we know that it only accounts for about 10% of all cancer diagnoses. The vast majority of cancer diagnoses are what we call sporadic, which means they're due to a mixture of genetic and environmental factors. There is a subset of cancers that we describe as being familial, and these are cancers where there's not one known genetic cause for the cancer, but we do see the same cancer, similar cancers running in a family. And that could be due likely to a mixture of shared environmental and genetic factors. But when we talk about these hereditary cancer syndromes, we're really talking about a relatively small percentage of all cancers. So some of the things that we look for when we think about hereditary cancer are younger ages diagnosis than average. We look for multiple cancers in one individual. We look for cancers that are related across many generations in a family. And we'll talk a little bit more tonight about what that actually means, what cancers are related by different gene mutations. And then we look for rare subtypes of cancer showing up more frequently in families. So hopefully this is helpful just to kind of level set, especially for those that weren't able to join the last time. So you'll notice a common theme as we discuss each syndrome, and we'll kind of walk through similar information for each syndrome. But we'll start with hereditary breast and ovarian cancer syndrome. And this is probably one of the most, if not the most well-known, well-described hereditary cancer syndromes for a number of reasons. We do know that the BRCA genes were one of the first to be discovered, not the first, but one of the first many, many years ago. We know that classic hereditary breast and ovarian cancer syndrome is caused by inherited mutations in either the BRCA1 or the BRCA2 gene. We know that these mutations are inherited in an autosomal dominant manner, which means that if you carry a mutation, there's a 50-50 chance that you would pass it on to your offspring, and so on and so forth. These mutations are typically present in families for many, 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 many generations back. They don't just occur out of nowhere. So they are always inherited. And then when we think about the prevalence, I would argue that this is one of the more common hereditary cancer syndromes when we're thinking in terms of genetics and very rare disease. We now think that the prevalence of BRCA mutations ranges from about 1 in 400 to 1 in 800. However, it's important to realize that this can vary very significantly by ethnic group. The most common, well-described example being we see a much higher prevalence in individuals of Ashkenazi Jewish descent, that their prevalence for BRCA mutations is about 1 in 40. So it's important to realize, and we talked about this in the last webinar, that having one of these gene mutations does not equal getting cancer. What these mutations do are put individuals at a higher than average risk for developing cancer. So here you can see what those averages look like, what those estimated risks look like. So the most common cancer risk that we can see in hereditary breast and ovarian cancer syndrome is, of course, breast cancer. And so in the general population, the average risk of developing breast cancer is about 12% or 1 in 8 over a woman's lifetime. And in individuals with BRCA mutations, that can range from about 60 up to 80%. So definitely significantly increased. Ovarian cancer is the other one that we typically see. In the general population, this gray bar here, that risk is about 1 to 2% for women. And in women who have BRCA1 or BRCA2 mutations, that can range to about 20 to 40%. And these differ based on the gene. BRCA1 carriers have a slightly higher risk for ovarian cancer. The other thing that we can see are second primary breast cancers in women who have already had one breast cancer. So that risk is significantly elevated over the general population. And then some of the other cancers that we can see tracking in the family are male breast cancer, prostate cancer, and pancreatic cancer. And these risks are very impacted by what, like I said, what is running in the family. If there's a strong family history of pancreatic cancer in the presence of a BRCA1 or BRCA2 mutation, then we tend to see higher risks for pancreatic cancer in that family compared to if there's no pancreatic cancer in a BRCA family, that risk would be lower. So the family history does impact the risk somewhat. So what do we do about those increased risks? This is, really where the importance of testing comes in, because those risks are there, whether someone knows about it or not. And knowing your risk, knowing your mutation status can empower patients and families to take steps to reduce that risk and even hopefully prevent the risk of developing cancer. So as we talk through all of these management slides, keep in mind that these are very high level, right? So an individual's management is going to be just that, individualized for them, their family history, their personal situation, other things, medical conditions they may have going on. So please keep that in mind. This is not meant to be taken and used for any medical decision making. This is just to give you an idea of some of the things that we can do to manage these increased risks and reduce those risks. So that's my caveat for the night, and that will carry through to each syndrome that we discuss. So for breast cancer management, and you'll notice a common theme as we discuss all of these syndromes, really what we are doing is screening earlier and screening more often. So for breast cancer, in the general population, women typically start between ages 40 and 50. However, in HBOC, we're going to start those patients screening between the ages of 20 and 25, depending on the family history. That would typically start with a breast MRI, which is not something that's typically done in the general population, and then adding mammogram in a little bit later. And some patients do actually consider what we call a risk-reducing or prophylactic mastectomy. So this is actual preventative surgical removal of the breast tissue in an effort to reduce the risk as much as possible. And there's also medications that women can take to reduce risk. For ovarian cancer risk, unfortunately, there is very limited screening like there is for breast cancer. We're quite confident in our breast cancer screening technologies that they can detect breast cancer at an early stage when it's treatable and curable. However, that's not the case for ovarian cancer. So it is a stronger recommendation to actually surgically remove the ovaries and fallopian tubes. And again, this age range varies. Doctors will typically advise between the ages of 35 and 40 or after childbearing. And another risk-reducing measure that women can consider is oral contraceptive pills. So the other cancers that we tend to see are prostate cancer. So there's not much additional screening that a male would do. They may start this screening a little bit earlier than the general population. And then again, for pancreatic cancer, that's really dependent on whether or not there's a history of pancreatic cancer in the family. And for those families that do have strong family histories, there are some imaging techniques listed here that would be considered for those family members. So for each of these syndromes, I also wanted to talk about, at a very high level, implications for children and what this means for children whose parents may have a BRCA mutation. So for HBOC, because it is considered an adult onset condition, right? We tend to see cancers developing, yes, earlier than average, but not in childhood. Testing is typically not recommended for children as it wouldn't change anything for their medical management. But again, that's a very personal decision and something to discuss with the doctor. We do know that in very, very rare cases, so this is where we're getting much more into the rare side of things than the common side of things. If an individual inherits a BRCA2 alteration, so if they inherit one from each parent, that can cause a condition called Fanconi anemia. Again, this is very rare, and it's something that can happen if both parents are carrying BRCA2 alterations. And this is associated with cancers that can occur in childhood, as well as a number of other signs and symptoms and conditions. So this is something that families, would typically be aware of if there was a risk for that, if they were both carrying a BRCA2 alteration. Beyond that, if there is, the more typical one alteration in one parent, those children may, depending on the family situation, if their parent was diagnosed with a cancer when they were a child, or if the parent was diagnosed and the child, lived through that with the parent, we want to make sure we're offering social and emotional support. There's many, many different ways to discuss BRCA alterations or genetic alterations with children, even if you're not doing testing. And it's a very personal choice of when and how to bring that up with children, depending on the personal situation, the family situation, and what else might be going on. So we will move on to Lynch syndrome, and you'll notice a similar progression here in discussion. So Lynch syndrome is caused by inherited mutations in one of 4 different genes, so MLH1, MSH2, MSH6, EpCAM, or PMS2. These are known as the mismatch repair genes. This condition also has autosomal dominant inheritance, similar to BRCA, so they're almost always inherited. If a parent is carrying a mutation in one of these genes, there's a 50-50 chance of passing it on to each child. And the prevalence here, some would argue that Lynch syndrome may even be more common than BRCA mutations. The latest estimates I saw were about 1 in 270 to 1 in 500. And the risks are different for Lynch syndrome than we see in BRCA. The 2 most common cancer risks for Lynch syndrome are colorectal cancer and endometrial cancer. So similar, you can see here that the elevated risk for colon cancer is upwards of 60% over an individual's lifetime, compared to less than 10%. Same for endometrial cancer, that range is about 40 to 60%, again, compared to about 5% in the general population. There is also an increased risk for ovarian cancer, up to about 20%, and then a number of other gastrointestinal and urinary tract cancers as well. Lynch syndrome is a little bit different in that there is a quite long list of cancers that have been associated with Lynch syndrome mutations. However, the ones that we see here are certainly the ones that are most commonly seen and the ones that we would do screening for. So what is that screening? How are we going to manage these risks? The most effective way to screen and also prevent colon cancer is an annual colonoscopy. Most of the cancers that form most of the colon cancers, I should say, that form in patients with Lynch syndrome start as what's called a polyp or a precancerous polyp, or also known as an adenoma. So these are small lesions that can actually be removed during a colonoscopy, essentially preventing the formation of colon cancer. So this is an extremely effective way to screen and prevent colon cancer. Not 100%, but very effective if it's done annually and starting at a young age, between the ages of 20 and 25. For gynecologic cancer, for both uterine and ovarian cancer, again, there's pretty limited screening. Some women may consider an endometrial biopsy starting around the ages of 30 to 35. However, again, oftentimes women will consider a risk-reducing total hysterectomy or removal of the ovaries and uterus to essentially reduce that risk as much as possible. For the upper GI cancer risks, patients would typically do an upper endoscopy at the time of their colonoscopy, typically starting a little bit later in life, and then a urinalysis to screen for bladder cancer and urothelial cancer. I will also mention that for some of the other more rare tumors that we might see with Lynch syndrome or in certain families, again, we would base that individualized management and screening based on what's present in the family and in the family history. So this is by no means, again, a comprehensive list, but just some of the more common screening that most patients with Lynch syndrome would undergo. So if we shift again to considerations for children, similar to if someone inherits two BRCA2 mutations in a recessive form and that results in Fanconi anemia, there's a similar event that can happen with Lynch syndrome. So, and I want to thank Parvati for this wonderful graphic here. So what happens when someone inherits two of the same Lynch syndrome mutation, this results in a condition known as constitutional mismatch repair deficiency, which many of you may be quite familiar with. This is a very rare disease, around 1 in a million. And again, this is inherited from both parents. So if both parents carry a Lynch syndrome mutation in the same gene, there's a 25% chance of passing that on to the child. This is a more aggressive cancer predisposition syndrome in children, where the cancers can occur very early in life. There's no cure or treatment, but there is an intensive screening and management protocol that we'll discuss on the next slide. And it's important to note that, similar to some of the other conditions, there can be risks for multiple different cancers. You can see some of them here. Sorry if it's a bit small, but we can see hematologic malignancies. That tends to be the highest risk, as well as GI cancers and brain tumors. But there's a risk of many other cancers as well. And so it's important to be aware of this and offer screening early and often for these different cancer risks. So what does that look like for a child that has CMMRD? It's a pretty comprehensive screening protocol. So moving towards whole body MRI, starting at a very young age, once a year, a brain MRI, of course, blood test, ultrasound, complete GI workup, as well as ultrasounds as well. So these are the current guidelines and, adapting all the time. But as you can see, it's very intensive to, do the best we can to catch those cancers early when they can hopefully be treated. So moving on to Li-Fraumeni syndrome, and this is where we're getting more into the rare. So you can likely see that from the prevalence numbers. So I want to preface this discussion by saying that, I'll be talking about classic Li-Fraumeni syndrome, which is a very rare condition. So about 1 in 3,000, probably more likely to 1 in 10,000. But as you'll see in this note, acquired TP53 mutations, and what that means is that as we age, as we get older, we acquire mutations in our genes. It's a natural part of aging due to environmental exposures and other things that we're exposed to over our lifetime. So acquired mutations in TP53 are very common as people age. And these acquired mutations can actually be so prevalent that they may actually show up on a genetic test for hereditary cancer, when in fact, they're not actually hereditary cancer mutations. So I just put this caveat here because as we have done more and more testing and tested more and more people for TP53 mutations as part of gene panels and different tests, we see more of these, I'll put quote unquote mutations, when in fact they're much more likely to be acquired. So I just put this caveat here to use caution interpreting test reports and meet with a genetic counselor because we are very well versed in talking through this very complex topic. But back to classic Li-Fraumeni syndrome, which again is very rare. This is caused by truly inherited mutations in TP53. The majority of these families are autosomal dominant inheritance, but something different that we can see in Li-Fraumeni syndrome is what we call de novo mutations. And what that means is that the mutation happens for the first time in an individual. So different from Lynch syndrome, different from hereditary breast and ovarian cancer syndrome, where those mutations have been present in the family for many, many, many generations. We're really not seeing de novo mutations. In Li-Fraumeni syndrome, we can see that in about 7 to 20% of cases, meaning that we wouldn't expect to see a strong family history of cancer. So classic LFS is a quite severe condition. You can see that this first blue bar here is for any cancer. For females, it's in the 90% range. For males, it's a little bit lower because, as you can see, the highest risk for females is breast cancer, but still a quite elevated cancer. And we do tend to see more rare cancers with classic LFS. So we do see sarcomas, which is a cancer of the bone or soft tissue. We can see brain cancers, and like I said, the bone cancer down here. The other thing, and we'll get into this in a few slides, but we do also see childhood cancer risks with classic LFS, and different from HBOC, different from Lynch syndrome. These risks can be present even if someone is just carrying one mutation in TP53. So for HBOC and Lynch syndrome, remember those individuals would, for those more rare, very aggressive childhood cancer syndromes, they would need to carry a mutation in both copies of their gene. With Li-Fraumeni syndrome, given the severity of just one TP53 mutation, we can see childhood cancer risks with this condition. So for management of Li-Fraumeni syndrome, for breast cancer, again, we're going to start early and often with breast MRI, with mammogram, and many of these patients, again, do consider risk-reducing mastectomy. For GI cancers, the colonoscopy and upper endoscopy starting in the 20s. Here you do see management recommendations for the pediatric population, which would involve a physical exam and complete blood count, as well as a whole body MRI and ultrasound, both starting in infancy. And there are some studies that are looking at whole body and brain MRI for adults as well to screen for many different types of cancer at once. So if we think about the implications for children with Li-Fraumeni syndrome, we tend to see quite rare cancers, so that are rare in the general population, but we see them showing up in these families. So we see adrenocortical carcinoma, choroid plexus carcinoma, rhabdomyosarcoma, and medulloblastoma, which all sound very scary, but as mentioned in the previous slide, there's screening that can be done. Testing is recommended if there's a known mutation in an adult for the family or for children with an associated cancer. And then, of course, as always, the social and emotional support for families that are dealing with this condition. So lastly, I will talk through neurofibromatosis type 1, which is a bit of a different condition. This wasn't actually historically first discovered or considered as a hereditary cancer syndrome. However, the more that we've studied it and looked at it, we have identified that there are cancer risks that can go along with NF1. So this is caused by mutations in the NF1 gene. There's autosomal dominant inheritance. The prevalence of this condition is about 1 in 3,000 to 1 in 5,000. So you can see the cancer risks here, which involve female breast cancer for adult females, this rare cancer known as malignant peripheral nerve sheath, and then paraganglioma and pheochromocytomas, which are adrenal cancers. Compared to some of the other syndromes that we've talked about, you can see that these risks are relatively lower, which kind of goes along with what I was saying, that it's not really known as a traditional hereditary cancer syndrome. It's more of a syndrome of all of these other systems that has cancer risk associated with it. So as you can see, there are a number of other complications or conditions that we can see with NF1. So typically someone would be diagnosed with this based on some of these other findings and not their cancer history. But once someone is diagnosed, then screening for these cancers would be recommended. So I will close with a few final thoughts. Hereditary cancer syndromes are rare, but prevalence varies by syndrome. And as you may or may not be aware of, awareness of testing, availability of testing, coverage of testing has all increased, which is wonderful, right? So this used to be not as well known. There was a lack of awareness. And through efforts of patient advocacy organizations, through providers who have expertise, we've kind of, and also I will also say that from notable people who have these syndromes, some of you might know that Angelina Jolie and Christina Applegate have BRCA mutations. So that, for better or for worse, also increases awareness of these conditions. So the more that we test individuals, the better we're learning about what the true prevalence is, but it does vary by syndrome. I will also mention that no two families with the same gene mutation will look the same. Within each of the genes that we talked about, BRCA, Lynch syndrome, TP53, there are thousands of different mutations that can occur. But even if two families have the exact same gene mutation, they will not look the same in terms of their presentation or the cancers that we see developing. Even within the same family, where it's, again, the exact same genetic and environmental exposures, some people will go on to live their whole life and never develop cancer, and others may have one or two or even three cancers at a very young age. So there's still a lot to be learned and a lot that we're navigating when it comes to individualized cancer risk, which is why we try to do our best when it comes to screening and management to balance that. And that goes along with the more we test, the more we learn, but also the more we realize how much we don't know. So back when I worked at Ambry, and even when I was in clinical practice, back before the norm in testing, and this is kind of getting into what we'll talk about in the next webinar, actual genetic testing, how it works, the process. Back when I was practicing, we used to do single gene testing. So we would only test a family for BRCA or only test them for Lynch based on what their family history looked like. But technology has advanced that we're now able to test for many genes in one panel in one shot, and that's becoming standard of care, the norm when people are pursuing testing. And the more that we've done that, we've realized that families don't always look like we expect. We may see a BRCA family with colon cancer or a Lynch syndrome family with breast cancer. So it's really supporting the idea that if you have a family history of cancer, if you are diagnosed at a young age, cast a wide net, try to get the answer. And when in doubt, we know how complex this is. We know this is changing every single day. So speak to a genetics professional, someone who has expertise in this area that's trained to walk through these results, walk through the testing process, and also provide support to families that are going through these and navigating these diagnoses. So I'll say thank you, and I'll stop sharing my slides so we can do questions.
All right. Well, thank you so much, Emily. We really appreciate it. So hi, everybody. My name is Cody Barnett, and I work on the patient advocacy team at Illumina. So I really just want to thank Emily again for walking us through this. And I also want to thank Parvati for creating space for this really important conversation. So I'm going to kick us off with our first question. And this is probably a very, as a kind of a good introduction question. So if someone wants to get started, but they want to talk to their doctor, they want to get tested, what is the first place they should go? Is it something they can just ask their primary care provider?
Yeah, like I said, awareness has really grown within primary care, especially within OBGYN. There's a lot more awareness and education. I would still say, if possible, it's best to meet with a genetics professional to actually pursue the testing. But, I think the primary care, the OBGYN could make that connection. You could also look to, if you have a local cancer center, or cancer treatment facility, they often have cancer genetics or high risk programs. So it's something that you could even just look up and reach out to those clinics directly. Like I said, even though it's in a cancer treatment facility, they often have high-risk clinics for patients who may not have cancer, but maybe at an increased risk to help facilitate the testing. So I think there's a few different paths. And I'll also put a plug out for the National Society of Genetic Counselors webpage. It has a lot of great educational information, as well as a Find a Genetic Counselor database, I guess, whatever you want to call it. So you can actually, look where you are and contact genetic counselors in your area.
I'll follow that up with a question we got during registration. I have Lynch syndrome. Should I get my family tested?
Yeah, so it's a very personal decision, of course. But as we talked about, if you have a Lynch syndrome mutation, there's a 50-50 chance that your siblings have it and a 50-50 chance that your offspring would have it. Again, typically we do testing closer to adulthood when it's going to make a difference in medical management. But again, that's a very personal decision. And, kind of as I mentioned when I was talking through the screening and management, knowledge is power, right? So if you have a Lynch syndrome mutation, if you know there's a risk, that risk is there regardless of whether you know it or not. So if you know that, then you can take the steps to do the screening, do the risk reduction surgery if applicable, and do everything in your power to reduce the risk. But it is a very, very personal decision. And we'll talk through some of the intricacies of genetic testing and some of the considerations that are involved in the next webinar. So, it's ultimately a very personal choice, and a lot goes into that choice.
Yeah. And following that up, we have another question about Lynch syndrome. So if someone has Lynch syndrome, but they don't have a strong family history of cancer, does that impact the level of screening or the frequency of screening that they should be receiving?
So that's a great question. So it doesn't for the common cancers that we see. So again, we're most often seeing GI cancers, both upper and lower, as well as gynecologic cancers, so uterine and ovarian cancer. So even if there's not a strong family history, we would likely still recommend screening for those cancers, right? Because again, it's going to show up differently in every individual. But I will say that a lot of some of the focus of the current research and where a lot of the studies are trying to get better risk estimates, not give such broad risk estimates for families. I think we're still very, very far off from giving truly individualized risk assessments, but we're trying to get better about, there's 4 different genes involved in Lynch syndrome, and we know that the risks differ quite significantly, whether you have an MLH1 mutation or an MSH6 mutation. So we're getting better about, providing more accurate risk assessments. But for now, again, to be more on the safe side, the screening is typically recommended regardless. I will say that for, again, some of the less common cancers that we see in those families, the family history would help to dictate screening, meaning like in BRCA families, if there's no family history of pancreatic cancer, we probably wouldn't screen for it. So it can impact screening recommendations, but not for the most commonly seen cancers.
Okay, thank you.
And not only we didn't share this in our presentation, but we have a parent here who's joined specifically for FAP and wanted to know if you can shed just a little light on it. She's still here, so I wanted to make sure I asked that.
Yeah, no, I mean, unfortunately, we couldn't cover every single cancer syndrome, but FAP is another one that we commonly test for. So it is due to mutations in the APC gene. And this is a colon cancer risk condition. The risks for colon cancer do tend to be higher even than what we see in Lynch syndrome. And the differentiating feature, kind of the hallmark feature of FAP, is the presence of dozens to hundreds to sometimes even thousands of adenomas, again, those precancerous polyps. And that is why we see the significantly elevated risk for colon cancer. So FAP actually stands for familial adenomatous polyposis. So again, adenomatous, those are the types of polyps, and then polyposis translates to many polyps. So for that condition, the recommendation would be ultimately removal of the colon, because the screening, although for Lynch syndrome, we see fewer polyps, so we can usually stay on top of removing them. With FAP, that's not always as possible. So the best way to reduce that risk is actual removal of the colon. And we can see risks in children with that condition as well. Those polyps can start developing in childhood. So if a family has a classic FAP, if they have a mutation in the APC gene, we would start screening in childhood. And that's a broad overview. There's some other caveats there, but yeah.
Thank you. So the other question we have is, why do different people within a family get different cancers?
Oh, I wish I knew. If I had the answer to that, I would, maybe be getting the Nobel Prize. No, I mean, not to make light of it, but it truly is. I mean, it's so complex. And I think it ultimately boils down to, in the most simple of terms, differing genetic and environmental factors, right? Even within families, right? Even if you're exposed to the same thing, if you have shared genetics, there's individualized factors there that we can't always predict. Our immune system is unique. That plays a role. So I wish I had a better answer, but it's just one of those things that we don't know.
And then Emily, if someone doesn't have a BRCA mutation, but maybe another genetic condition, is it still possible that they could have an increased risk for breast or ovarian cancer?
Yes. There are, again, tonight we were just covering some of the more well-described syndromes, but many of, I kind of mentioned cancer panels, and again, we'll talk about this more in the next webinar when we talk about genetic testing, but many cancer panels now cover dozens, up to 80 genes, many of which are linked to increased risks for breast cancer. I will say that the ones we talked about tonight, BRCA, TP53, are still associated with the highest risks, but there are many additional genes, some of them which have a more moderate penetrance or moderate risk, increased risk for breast cancer, but that we are commonly testing for, and that also have screening recommendations as well. So it's very possible that someone could carry a mutation in a different gene that elevates breast cancer risk. These are by no means the only genes involved.
I think the last question we're going to address, are there any precautions we need to take for our children to prevent them from developing cancer? And then follow through after that would be just mention of the.
Yeah. So, I mean, I think I often got this question when I was counseling patients and beyond actually following the guidelines, doing the testing, doing the screening. I often thought about, what can you control, right? Like what is within your control? There's so much that's outside of our control. And, the most basic things of eating well, exercising, getting enough sleep, the things that seem very, very silly when we're talking about these elevated cancer risks. But I would say, be vigilant about meeting with your providers and learning about what, if any, risks are involved in childhood. If there aren't risks until adulthood, that's a different conversation, but whatever you can control that keeps you healthy, I think is the best recommendation there. And so, so perfect. Were you going to pull up the slide for the next webinar, or did you want me to? There you go. Yeah, so as I've alluded to, in our next webinar, we're going to talk more about the actual genetic testing process for hereditary cancer, what's involved, what some considerations are. And so we hope you'll join as well.
I wanted to mention that because one of the questions that we're going to save for next time is about cancer panels and genetic testing.
Okay,
so, yes.
Great.
We look forward to seeing you all next time. Thank you, Emily, so very much for your patience and for adjusting for all our different time requests and being here and discussing in length and answering all our questions perfectly. We are so thankful for your time. Thank you, Cody, for helping me put all of this together. We will see you next month at the next webinar.
Thank you so much. Take care.